I was involved in several clinic construction projects, so I know exactly how challenging and actually scary some of these can be, especially when you have limited resources and you're really doing this sometimes for the first time. You don't have a lot of experience in building a new clinic. So having access to others who've been through this before, like you will have today, national experts from community clinics, but also outside of clinics, experts in healthcare design, it's really to help you think about how to build and design your buildings in new ways. And that can be critically important to developing a successful new facility. You're going to all learn today about how buildings are being designed in flexible ways to reflect their culture. And really, you can learn from some of the folks that have been through this before and national experts that the center has brought together. And it's a really exciting day ahead. The Center for Health Design has also developed a lot of resources, so look in your packet. There's a lot of information there. There's new research that's been done that will be shared today, and there's a fabulous new website. So you can continue to work on networking and sharing ideas with each other even after you leave and with people who are not even here today. I'm excited about the day ahead, starting with Ian Morrison. You're in for a treat. He's very thought-provoking and entertaining, so I think that will be a great start for the day. And again, I want to thank the Center for Health Design for all their work in bringing together everyone today. And I want to go ahead and introduce Deborah Levin, who is the CEO of the Center for Health Design and has provided amazing vision and leadership and has been a fabulous partner for the Healthcare Foundation. Thank you.
Thank you, Melissa. I want to first give a shout out to Melissa because you have truly been a great partner to work with. That I hear over and over again from the team that you help keep things on track. You've had great vision, and you've really helped to shape a lot of what everyone's going to experience today. So thank you. But I also really want to thank the California Healthcare Foundation. That the Center for Health Design is in one of those positions where we're only able to do great work when we have great partners. That as a nonprofit, our revenue streams come from a variety of different ways, but specifically we partner with for-profit and nonprofit to create the funding to do things like we're doing today. So I really thank the foundation for their ongoing support. And I want to thank all of you that I know every day we have 500 things on our to-do list that we know we're going to only get a fraction of them done. So it really says a lot about all of you that you've taken the time to spend a day or 2 days or 3 days to come and be here and be a part of this program. So thank you. So I know that most of us are from California. So if you're from California, let's give a shout out. How many of you are from California? Okay. But I also hear that we have people from actually all throughout the country. I met somebody at breakfast from Rhode Island. So where else are people from, just to get a sense of where everybody's from? Just shout out where you're from. What state? West Virginia? New York? Any others? I had heard we have people from Colorado. So thank you all for being here, and especially those of you who traveled. We really appreciate it. So today, as Melissa said, is actually the culmination of 3 years worth of work. This whole project that we're here to experience today started 3 years ago when the foundation said, would you guys be interested in doing a white paper on ambulatory care design and find some exemplary facilities in the state of California that we might be able to use as shining examples? And so we did that, and to the foundation's credit, they had a greater vision in mind, and they took that seed of information and created these white papers, the website, and worked with us to create all the things that you're going to experience today, which is really a roadmap to how to best understand the relationship between built facility design and outcomes. How many of you have heard of the Center for Health Design before today? Very few. And how many of you who have heard about the center are from the healthcare community versus the design community? Great. So for those of you who don't know who the center is, and that seems to be a large percentage of you, the center is a 501c3 nonprofit organization. We're located maybe 90 minutes from here down outside of San Francisco in Concord, California. And we're all about understanding and making the connections between the built environment and outcomes in healthcare. We really believe that a well-designed physical environment can reduce stress to patients and staff, reduce medical errors, improve patient outcomes, and even reduce the burden of cost to the healthcare system. And for over 20 years, we've been engaging in research education and advocacy efforts to uncover those connections and then broadcast them to the world so that people can make better, more evidence-based design decisions, whether they're involved in a billion-dollar acute care hospital project or a $10,000 renovation project. So today we're here to talk to you about clinic design, but our body of work actually covers environments all the way from the scan of acute care environments to long-term care environments to even how healthcare can better be provided in the home. Because we define environment in a much broader sense than just the bricks and mortars. And we work to really understand that relationship between the built environment and, say, staff culture, or the impact that technology has on the built environment, and even the relationship between the building and community involvement in healthcare. So if you aren't familiar with us, our website is everywhere that you have information. I encourage you to go to www.healthdesign.org and learn a little bit more about our broader scope of information. Most of our resources are free, and though they may not be relevant to the work you're doing, they may be relevant to some of your colleagues. So if you could help us by helping spread the word about the center's work, we would really appreciate it. So as I said earlier, we're really here to talk about clinic design and to share with you best practices, design principles, resources, and tools that really have been developed specifically for you in this audience. There will be opportunities for peer-to-peer learning, for you to network, and for you to learn from a diverse group of people, and that includes architects and planners, and have access to experts for real-time feedback on some of the some of the projects you might be working with, or some of the problems you're trying to solve. As Melissa said, unfortunately, we just didn't have room for all of the people who wanted to be here today, so all of our keynote presentations are actually being recorded. They're being streamed live, and they're also going to be on the Clinic Design website. So if there's anything that you want to go back to, you want to hear again, you want to have some of your colleagues access, they'll all be available and archived on that Clinic Design website. And I also want to encourage you to sign up for the Clinic Design Community Forum, because though this is a great day and you're going to meet a lot of great people and have access to a lot of information, that's how this is going to live beyond for years and years. So if you want to continue to have this kind of interaction, to talk with people, to ask questions, to create a community for yourself, that's the forum that's going to be available for you to do it. So I really want to thank you all for being here, and thank you for the incredible work that you do day after day after day, and for really the part you play in creating better healthcare environments and quality healthcare. So it's now my pleasure to introduce, I have this mental list that I keep of like the top 5 favorite people, and it changes all the time, but on my top 5 favorite people list is Ian Marson. That I was very fortunate that Ian joined the board of the Center for Health Design and sat on our board and on the executive committee for 7 years, and I never have stopped learning from him. You know, for me, Ian was kind of the spoonful of sugar that helped the medicine go down. That what he was saying I may not have liked, I may not have wanted to hear, but somehow how he says it with that accent and that wit, it made it all okay. So Ian, I personally want to thank you for all of your insight and your wit. And in many ways, Ian's a bridge between the California Healthcare Foundation and the Center for Health Design, because Ian actually also sits on the foundation board and as of last month is their current chair. So Ian is an internationally known author, consultant, and futurist, specializing in long-term forecasting and planning with a particular emphasis on healthcare and changing business environments. He authored the 2002 book, Healthcare in the New Millennium, Visions, Values, and Leadership, and his previous book, The Second Curve, Managing the Velocity of Change, was actually a New York Times business bestseller and a Business Week bestseller. Ian has written, lectured, and consulted on a wide variety of forecasting, strategy, and healthcare topics for government, industry, and a variety of nonprofit organizations in North America, Europe, and Asia. He has spoken to a range of audiences from the boards of Fortune 100 companies to the Chinese Academy of Social Sciences in Beijing. He has worked for more than 100 Fortune 500 tech companies in healthcare, manufacturing, and information technology, and financial services. He's a frequent communicator on the future for television, radio, and the print media. He combines research and consulting skills with his incisive Scottish wit to help public and private organizations plan their long-term future. So you're really in for a treat today. For those of you who haven't had the opportunity to meet Ian, I know you're in for a great presentation. So Ian, please. Thank you.
kind introduction. Good morning, and nice to see everybody. Yeah, it's kind of, Deborah was looking for a Scottish, Canadian, Californian healthcare futurist who had an affiliation with both the Centre of Health Design and the California Healthcare Foundation, and there wasn't a big list of people that fit that bill, but so I'm delighted to be here for all of those reasons that you pointed out. So my job is really to give you kind of the context setting for what you're going to hear today. My only qualification really is I am a Scottish, Canadian, Californian, which gives me a unique perspective on healthcare and all things to do with healthcare, including death and dying, because the Scots see death as imminent, Canadians see death as inevitable, and Californians see death as optional, actually. You know, my background, actually, it's interesting because I know many of you in the room are design professionals. I'm the son of an architect. I actually was trained as an urban planner, but I never practiced. And I came to Canada in the late 70s. I couldn't get a job in urban planning in Vancouver, but I did get a job working as for Management Engineering Unit 13.1, which was the Canadian healthcare equivalent of the KGB, basically doing clinical re-engineering before it was called that back in 1978. And started a career and a love affair with healthcare, which has continued ever since, and spent most of my time in healthcare, although I have worked in other industries, and did my doctorate in health policy and health economics in Canada, and came to California in 1985 to work for a group called the Institute for the Future. So I've been in the futures business in healthcare for a long time, and I had the great honor to serve on the Centre for Health Design's board, and as Deborah mentioned, very proud to be affiliated with the California Healthcare Foundation, although I'm not speaking for the foundation. Melissa speaks for the foundation. She's the person to talk to. I sit on the board, and I'm very proud to do so. So what I thought it would be helpful was just to take a few minutes to sort of set up why it's so important that the work you do works out well, as it does, and as Deborah says, the hard work you do every day for Californians. And the title I've taken is The Future of California Healthcare, Life in the Gap, Life in the Game. What that refers to is the gap between now and full implementation of the bill in 2014. And let me give you away a little secret is it may not happen because I've been in 32 states since health reform passed and 10 countries as well. It is not universally adored across America, I have to say. It's more popular, actually, in the 10 countries than it is in Oklahoma. So there is some probability that it may not happen, but we have to move forward with the assumption that it will, because it does create significant changes going forward. So I want to go through very quickly what this means, particularly for the California healthcare system and specifically the community clinics and the safety net within California, and maybe why design is important for that issue. So I'm going to touch very quickly on some driving forces creating change. The first is obviously we have gone through almost close to an economic Armageddon, which we avoided, but it has certainly impacted healthcare. It's increased the uninsured and underinsured. We're in search of a new economy, and we're still finding our way in that. Basically, the answer to California is Facebook, I think, as far as I can make out. It's 500 million people who are saying what's up to each other online all day. That seems to be our new economy. But we have huge pressure, as we all know, here in Sacramento and in our nation's capital in terms of budget deficits, and I'll touch on that a little bit. And the community clinics are in a unique position because despite all this economic turmoil, they've been the beneficiary of significant investment from the federal government through health reform and through the Recovery Act. And they are sort of in a unique position, loved by both left and right for different reasons we could get into. So I'm going to give you a little bit of an update as I see it from the both federal and state level. And I'm going to draw, when I do that, heavily on my colleague. I have a partnership with the Harris Poll and the Harvard School of Public Health. And so we survey a lot of stakeholders and interpret it for our client group. And I was just with our clients and my partners last week in New York. And Bob Blandon, who is, some of you may know, a distinguished professor at Harvard, expert in politics and policy of healthcare. I'm going to channel Bob and share with you some of his insights and our insights about where we're headed. So anyone who doubts that healthcare impacted healthcare, just look at or that the economy impacted healthcare, you just have to look at the slide. This is from the Commonwealth Fund. A full 15% of Americans spent more than 10% of their income on premiums last year. 32% spent 10% or more of their income out of pocket on healthcare, which is astonishing numbers. And a lot of Americans, 25%, skipped a test or treatment because of cost. So the cost shifting, the rise of the uninsured has had significant impact on access to health care for many people. Now, the other thing to understand as we go forward is that we are a divided country in terms of our ideology and our politics with very different views. 2/3 of Republicans think we have the best health system in the world. Only 1/3 of Democrats believe that. And there's no convincing either side. I mean, the polling is quite interesting, but it's really a distraction. No one's changing anybody's mind about this stuff. We are deeply divided, as I said, and the divisions are even more extreme in Congress because of the way in which we elect our representatives. And the budget battles, both in the short run and the long run, that we'll see over the next year are going to be quite interesting and perhaps vitriolic. The law will pass if Obama is reelected in 2012. If not, it might not. I mean, the law is the law of the land, but there is no law that says you can't repeal it if you have a significant Republican majority in both House and Senate and you control the White House, and that may happen. Medicare reform, which you'll hear a lot of posturing about in the next week. Congressman Ryan is proposing that we essentially create, they don't like the term, voucher system for Medicare. So if you're over 55, you're fine. The rest of you are all screwed. I'll be okay. We will get into that debate, although I think it would be political suicide if the Republicans were actually to present that as a serious policy position for 2012. We could talk about that. And there are a number of wild cards which I'll get into. So just to channel my colleague Bob Blendon, understand, and this is not a poll, this is, well, it is a poll, but it was taken, these are of voters, so it's not just a survey over the telephone, these are exit polls. There is a big difference between Democrats and Republicans in their view. The thing to note is that among Democrats, 59% think the bill is insufficient. They want to expand it, right? So, I mean, the left believes we should do more. And you can see, Democrats like the bill, Republicans hate the bill. It's as simple as that. What's important to note is the 2010 election was not a stunning endorsement for Republicanism in the sense that it was a very low turnout election. Only 42% of the electorate turned out. If you ask yourself the question, when 60% of people turn out, as they probably will in 2012, who is that 18% difference? And it tends to be African Americans, Latinos, and the Twitter crowd. My kids, the 20-somethings who were on the couch watching Rachel Maddow during the 2010 election. So we may see a different result, and I think there's been a bit of an overreach, and quite honestly, in some of the states across the country. So we're going to see major conflicts over the bill. There's going to be some debate and posturing around Medicare reform, but probably not much change. What is significant is that there will be real efforts by the Congress and the House in particular to sort of defund what could be defunded in the implementation of health reform, and a lot of kind of investigations and challenges to the administration's implementation of it. And you're going to see Democratic state governors will start planning for implementation. We've done it in this state. We have an exchange. We have passed a law. We have got a board. We're having meetings. The foundation is supporting much of that. And other states are going to move much more slowly. I mean, I'm doing work right now in Oklahoma, for example. Oklahoma got a grant to establish their exchange, and then promptly their state senate turned around and said, we're not going to pass the legislation to enable us to accept the grant because that would be, quote unquote, marrying Obamacare. So there is enormous variation across the country. Again, the polls tell us that roughly the country is divided. Just when the act was passed a year ago, it was 40-41. It's now 45-44. nobody's changing anybody's mind here. The country is basically split. After the election in 2010, and this is a poll from about a month ago, there's no real change in the picture. Republicans and Democrats have just very different views about the law and about whether they should repeal it. So about 40% of people want to repeal the bill, about 30% want to keep it, and 30% don't know. Now, the interesting thing about people want to repeal the bill, except for the things that are in the bill, right? Which I find a little bit amusing. So you don't have to actually read this chart. You just have to see that the blue is bigger than the red. And what that means is that when you actually ask people, what is it you want to repeal, they don't want to repeal anything. The only thing they want to repeal in a majority is the individual mandate. Everything else has a plurality or a majority of people in favor of keeping the provision. When people say they're against it, and when you survey and ask them among those who are against it, why are they against it, they see it in the big picture sense. The government takeover, it's too expensive, it's socialism, etc. So, in summary, what we see with health reform is that if it stays in place, we're going to see a massive expansion in coverage. And this is the relevant part for all of you. Basically, in California, we would see about 2 to 3 million people added in terms of expansion of Medicaid. That's a big number. And another 2 to 3 million, some would argue even more, through health insurance exchanges. What we've seen in our bill so far with the exchanges is that safety net providers are, in theory, granted most favored nation status. They are supposed to be at the table in all of the plans that are going to be offered in the exchange, although I think people in the safety net community are concerned that they may not be competitive in terms of pricing, and we'll get into that in a second. We have a Medicaid waiver in this state, which is supposedly going to give us a footbridge to this new future by allowing us to gear up in our expansion of Medicaid coverage, but that's against the backdrop of an inability to pay from a state budgetary perspective. And obviously, over time, there are concerns that we change the delivery system using accountable care in medical homes in a way that's very different for the future. All of this is going on when there's substantial private sector realignment in preparation for health reforms all over the state of California, and everybody wants to be an accountable care organization, and we could get into that whole rhetoric if you like. In terms of the broader picture of health reform, the basic problem is affordability. The average family cannot afford the average premium. And when you think about it, that's a wee bit of a problem, right, if you do the math. And basically, health reform is a system whereby the top 2% of folk, those earning over $250,000 a year, are going to subsidize almost everybody else. And the question is that going to be sustainable in the long run? The reason health insurance is expensive is because healthcare delivery is expensive. It's a convenient fiction that all the money is leaking out to insurance companies and they're making out like bandits. Well, they are, but that's not the reason healthcare costs are high. The reason healthcare costs are high and healthcare premiums are high is because healthcare delivery system is expensive. Doctors and hospitals collectively account for most of the money. And we, the public, don't want less than we want now. We want more, and nobody wants to take a pay cut or be denied even ineffective care. And that's a bit of an issue in terms of changing the system. So those of you who come from the design professions and maybe don't agonize over health reform as much as those of us in the healthcare business, let me give you the simplest version I can of what the bill requires. It's going to expand coverage by 32 million nationally, half of that coverage expansion through exchanges, half through Medicaid expansion. It will regulate insurance significantly, and the bargain that has been struck in the bill is basically that in return for guaranteed issuance, in other words, insurers have to issue on an even-handed basis regardless of your health status, we have to have an individual mandate, right? You can't have one without the other. And it is paid for nominally by expansion in taxes on those over $250,000 and givebacks from the healthcare industry. What many of us are excited about is the promising pilots in terms of reimbursement reform, because many of us believe the reason why we're in this mess is because we pay on a fee-for-service basis. And that's what led us into doing way too much stuff with a particular focus on procedures. And so there are lots of interesting pilots, and we just really don't know at this stage whether they work or not. So if you look at the big picture of health reform, you could argue that there are really 4 scenarios. The first scenario is, we see an economic recovery. I believe that if unemployment is under 8%, Obama gets reelected, the law will get implemented pretty much as is. An alternative would be that we see Republicans in the White House, scenario 2, and in the Congress, and that the law is substantially repealed. We basically go back to a situation of repeal and replace, which would mean you'd probably see a very modest set of proposals put in the replace part, and we'd have continuingly about 50 million uninsured. That would be a big, big challenge for the community clinic environment, and they may actually be beneficiaries of getting even more money in that environment, but they might be overwhelmed by the number of people at their doorstep. A third scenario is building on Obamacare, that we actually do find out how to do accountable care and reimbursement reform, and we do see promising results from these pilots, and that we actually change the reimbursement system to reward health status rather than pay for procedure, which is kind of where we are in the health delivery system. And then the bottom right-hand scenario is not particularly pleasant, which is one in which we find out we're not smart enough to figure out how to do reimbursement reform. All we're going to do is cut the prices and essentially whack provider reimbursement at both Medicare and Medicaid. If Republicans are in charge, this would be just for public programs. If Democrats are in charge, you can imagine a world like that where we whack the prices for everybody in kind of an all-payer rate-setting environment. Now, none of these, I'll tell you the scenario that's not available, that we suddenly find $1 trillion under the mattress and we give it to healthcare without asking any questions about what you're doing with the money. That ain't available. That's what we just did in the last decade, and it helped us get into the mess we're in. So those are the kind of big scenarios, and I'll talk about the safety net in a second. Now, I just want to touch on what is obviously a sensitive subject, within 2 blocks of here, which is the state budget situation. If you look across the country, and I shamelessly stole this from Chris's presentation to the board, Melissa, you will recognize the slides. But basically, if you look from 2001 up to 2008, state revenues grew up about 40%. This is all states, not California, all states in the nation. Medicaid grew by 53%, and the burden was sort of shared evenly between federal and state in terms of the rate of growth. If you look at what happened in the 2-year period, 2008 to 2010, because of the provisions of the stimulus bill, the feds picked up the slack, right? So they saw their Medicare bill go up by 41%. Medicare expanded in that 2-year period alone by 25%, Medicaid, and most of it, all of it just about, was taken up by the feds. The thing that's important to understand right now in this previous year, because stimulus has ended, is that all of the burden of the increment in the last year is felt by the states. And this is going on all over the country. So their burden has gone up in 1 year by 41%, whereas the federal burden down by 7%. And this is causing angst every state I've been to in the last year. Now, we all know the picture, and depending on your politics, you have different views about how to balance the budget. But this is true of whether you're talking California or Oklahoma. The percentages are almost identical. 90% of the budget is K through 12, Medicaid, higher ed, and prisons. That's it. That's the budget. So pick what you want to cut because you can't, there's no, and the federal level, it's a different set of buckets, but it's the same problem. You can't balance the budget by cutting NPR. Let me put it that way. So the other point to note is the variation across the country in terms of exchanges. The reason I raise this is that we are the most activist state outside of Massachusetts in the creation of a health insurance exchange. We have, as I said, passed a law. We have a board. We have 4 out of the 5 members appointed, and we're having meetings. I mean, sponsored by the foundation, I was at one of them, and we are discussing in the state of California a bunch of different options. Some people believe we should just get more folk covered. Some people believe we should use the exchange to be an activist exchange that encourages delivery system reform, particularly accountable care organizations. Some people believe we should use this as an opportunity to expand the commercial insurance market and bring more commercial insurance choices to everybody. Some people believe we should recreate, this is Kaiser basically, anyone from Kaiser here? Good. My friends at Kaiser believe that we should have I'm giving a talk to Robbie Pearl's board next week, so I'm a big fan of Kaiser. Yeah. Oh, you're a patient? Oh, yeah, not a member of Kaiser. But the point here is Kaiser's preference would be that if you are a small business and you're getting your health insurance through the exchange, that one employee could pick Kaiser and one could pick Blue Shield of California, and that would be enabled by the exchange. Others believe that the small group market would function differently from that. Some people believe that since the exchange would serve primarily low-income people, that we should blend Medicaid and the exchange, and they'd be very tightly coupled, since it's the same humans that are going to cycle between those two programs. Others believe we should support the safety net and bias the exchanges towards preserving the safety net, since they're the folk that hang out with the people in need and will be there for them no matter what. By the way, that was the least popular view among the group that we talked to. And then some people believe that we should set up the exchange so that businesses can get out of the business of health insurance in the long run. So these are very different choices, and the board will have to decide with advice from others as to what that's going to look like. And you should all, in this room, weigh in on what you think ought to have happen. But it will have an impact in terms of the competitiveness that the safety net environment will have to face. And that really is my point in raising it this morning. So the way the health reform bill is headed, we're going to have this weird period between now and 2014 where not much happens, right? And in the interim, costs are going to go up. Employers are going to shift costs to employees. Small businesses are going to drop out. The number of uninsured will go up. When the COBRA provisions run out, we're going to see, I think, we've currently got 52 million uninsured. It may be 55 million by the middle of the next year if we don't see robust economic recovery. And, if you think about what all these state budget cuts mean, is one of the provisions is we're basically whacking school teachers and firefighters, right? Who has the best health benefits in America? School teachers and firefighters. And yet they've become the enemy somehow throughout America. Somehow it just shows you how bad the private sector job picture is when working for the DMV is the hot ticket, right? Now, if the law stays in place from 2014 and beyond, then we have a very, very different world. The first thing is we'll have a massive expansion in coverage. Now, what happened in Massachusetts when they got an insurance card? What do you think happened when people got an insurance card? They turn up, right? And where do they turn up? They turn up at the emergency room. Why? Because they can't get in to see a doctor. So we can't just ask the primary care doctors of America to give it the college try and see 30 million more people, right? That ain't going to happen. We have got to start very, very quickly, and this is safety net, community clinics, and private sector, as I'll show you in a second, the community clinics are not the only place the uninsured go to, is we have got to retool and redesign primary care delivery in America very, very quickly to be better, faster, cheaper. And by that, I mean not just throughput seeing doctors, but changing the way we do what we do. I'm on a mailing list from, email list from George Halverson at Kaiser, and he sent an email to his folk a few weeks ago which said 10 million, 8 million, 2 million. That's all the email was really about. That was the headline. And what he meant by that is 10 million were the number of e-visits that Kaiser had last year. 8 million was the number of prescription renewals where nobody had to get in the bus and go to the doctor to have their prescription renewed. and 2 million were the number of same-day appointments made online at Kaiser. That's a transformed delivery system. That's using technology to do things differently, and I think that's part of our solution. So there's lots of other things that may happen, but the most important thing I want to signal here about 2014 and beyond is this massive influx of folk. Now, I think, and you don't want to overplay that, because most of the uninsured are not sick, right? You know, I mean, they're mostly young people, but some of them are, and there will be, no doubt, a surge, as I call it, when everyone gets an insurance card. Now, there's winners and losers out of reform. I mean, it's good for low-income people. It's good for folk with chronic conditions. It's good for small businesses who are on the cusp of providing coverage but couldn't quite afford it because they'll get a tax credit. It's good for worried parents because you can actually keep your kids on till they're 26. Why not? They don't leave, you know. You know, I have a 26-year-old son, and he's trying to convince me that it's in the healthcare law that I have to pay his cell phone until he's 40, all right? It's good for primary care physicians. It's good for, by the way, I just did a retreat for all the chief executives of all the Canadian provinces last week in Palm Springs. The average primary care income in Canada right now is $240,000. It's twice as much almost as the US. And that's true in the UK too. We do not honor our primary care physicians here in America. It's really ridiculous, the skewed nature of compensation towards specialty care. Anyway, that's a rant. So it's good for drug companies because it could have been a hell of a lot worse for them. I could explain why I say that. It's good for elderly who are not in Medicare Advantage, but the elderly hate the bill. They're the ones who elected the Republicans because they hate the bill. And it's good for self-insured employers. Biggest losers under reform, tanning salons, okay? This is a true story. So, do we have a minute? How are we doing time-wise here? It's an insight into our political process. So, when they were trying to find money for health reform, they had to keep it under $1 trillion, right? This is back a year ago before the bill was passed. So some smart Alex staffer on the House side, I think he was like a 12-year-old kid from Harvard, right? And so he came up with this idea in the middle of the night. We could get some money by taxing cosmetic surgery, right? Brilliant. So they thought, rich people, discretionary, perfect. No one's going to complain about this. Then the wrath of God came down from the American Medical Association and the American Society of Plastic Surgery, right? Now, I work for the American Society of Plastic Surgery. They're clients of mine. They are beautiful people, but you do not want to mess with these people, right? So they said, don't tax us. Tax something that is clearly discretionary, clearly cosmetic, and clearly medically harmful, namely tanning salons. And as of July last year, there is a 10% sales tax on tanning salons, paying for health reform even as we speak. Snooki is pissed, I'll tell you this. Anyway, so it's not good for health insurers, even though they get 32 million new customers. And by the way, if you follow the stock market, health insurers are the hot new item, right? Their stocks are up hugely in the last year. It's not good for rich people. It's not good for insurance brokers. It's not good for specialists. It's not good for 30-plus youngsters. Terrible for medical device manufacturers. Not good for seniors on Medicare Advantage. Not good for hospitals with open doors necessarily. And it's certainly not good for states who didn't want to expand coverage to poor people in the first place, right? So there are winners and losers, and that's why it's so politically contentious. Now that takes me to the safety net. And the important thing to understand as an outsider to the safety net is when you actually look at the data and you say, what is the safety net? The interesting thing is that some providers in the safety net, like community clinics, care exclusively for safety net populations. They're not seeing a lot of well-insured people, right? However, it's true that non-safety net providers provide a significant, and as it turns out, a majority of the care delivered to folks of low income, right? So that's the kind of conundrum here. It's just to make the point, if you look at primary care community clinics, this is again stealing shamelessly from the California Healthcare Foundation work, the 56% of folks visiting primary care clinics are Medi-Cal or healthy families, and about 22% are uninsured. But you ask the other question, what is the market share of community clinics of the uninsured? And it's actually relatively low. It's about 17% of those who are uninsured are seen at community clinics. The residual, 83%, are seen in other places, right? So the private sector, the public hospitals and other places are a significant part of the care for the uninsured. So it's not an exclusive relationship that the community clinics have. Now, it tends to be that market share is somewhat higher if you look at the poorest of the poor, those who are earning below 100% of the federal poverty level. It's not quite as high for those above 200%. Sorry, between 100 and 200%. So the market share is somewhat lower there. Now, the reason I say this is that it's important to understand that when we're talking about the safety net, we're talking about community clinics, about what role they play in the broader market I just described. Now, the safety net is not doing its thing in a vacuum. We are seeing tremendous consolidation in the private market, hospitals consolidating regionally, physician groups consolidating, and so forth. And we're also seeing them, playing with these broader risk envelopes of accountable care and so forth. And there is significant cost pressure on the the entire healthcare delivery system to try and make money on Medicare, which means taking costs out to be competitive going forward. So that's the backdrop, if you like, of the delivery system in the state. And so it's against that backdrop that community clinics have to compete for business in the exchange and potentially for Medicaid, to be honest, because there's a lot of new entrants with private equity money in the Medicaid-only market that I think you're going to see over the next couple of years. So one of the things you have to be competitive on is price. The Shoemaker principle refers to Wells Shoemaker, who's the medical director of the California Association of Physician Groups, who early in his career, he's a very noble young doctor. He set up a free clinic in San Joaquin Valley to care for migrant farm workers. And at the end of the year, he added up all the grants he got and all the patients he saw, and he divided one number by the other number and found that despite his noble intentions, his cost per case or cost per visit was 3 times as high as the local doctor, right? So I've called this the Shoemaker principle. We've got to really make sure that the way we're treating patients is better, faster, cheaper, regardless of who it is that's treating them. And sometimes maybe the community clinics are not cheaper. They may be more expensive if we do the math. A second question is, can existing providers flourish and grow? And I think I'm trying to make a case here that clinics will have to earn the business, if you like, because when safety net populations have choice, they maybe choose to go somewhere else if they get a card. And you could argue this both ways. When folks in Alameda County and LA had the opportunity to go to mainstream providers rather than safety net providers for their OB, they shifted, right? Others would say, well, the county organized Medicaid systems have been able to market against private insurance and take 70-30 share. So I just raise this as an issue of competitiveness going forward. And then there's a whole bunch, much of this is drawn, by the way, from a piece of work that I did for the Blue Shield Foundation, who had sponsored a summit on the future of the safety net, so I'm stealing shamelessly from myself here. And the other thing, and this was all based sort of in interviews and leaders in the field, is that we have kind of an interesting set of mission, culture, management, and leadership issues with regard to the safety net. The safety net has fierce independence. They are dedicated to the communities they serve, but there is a sort of slight tinge of self-righteousness occasionally and that goes with that fierce independence about send us the money and leave us alone, right? There isn't as much interest in the mega trend of the moment, which is consolidation, integration, accountable coordination, those are not words that you see as much in the safety net environment. And there's been historically, and this may be a little unfair because the Foundation has done great work in trying to encourage standardization and performance measurement, there is a certain amount of resistance to that once seen over time. So it's against that backdrop that the community clinics may be in a very different world going forward. And we went through a whole series of scenarios. We don't have time to go through these. The punchline is you have to be able to compete on a service basis, right? That is going to be an important part of community clinics' future. And I think design could be a very significant part of that. Now, for the architects and designers in the room, Deborah will recognize this, the thing I did at the ASHI meeting recently. As the son of an architect, I know the greatest thing you want in architecture is a sponsor, right? A rich sponsor. These are some of the great buildings of the world. By the way, the castle on the bottom left-hand corner is Bothwell Castle, where I grew up in Scotland, one of the finest examples of medieval architecture built in 1242. But all of these things have in common a sponsor, right? And when you think about it, the Medici of our age has been healthcare, right? I mean, the fanciest buildings that we have tend to be healthcare buildings. And I think that's been fun. It's been a nice ride, and the architects of the world have enjoyed that. What I would say going forward is to think about less grandiose future for design. And the evidence I would give, this was my epiphany moment in the last month, is I got to go to Walmart to give a talk. This is the home office of Walmart in Bentonville, Arkansas. Anyone ever been to Bentonville, Arkansas? There we go. What a treat sensation it is to go to Bentonville, Arkansas. I'm telling you, man, I was really impressed. So the reason I show this this isn't a bad strip mall of dry cleaners on the right. That is the executive suite of Walmart. There are only 12 people who have a window at Walmart. That is the office of the CEO, Michael Duke. He made $35 million in compensation in 2010. My point is that when it comes to better, faster, cheaper, there is no better, faster, cheaper than Walmart. And so what we might want to be thinking about as we go through our deliberations, and it's just a personal plea to you all, is as we think about building better buildings and better clinics using evidence-based design and using high-quality initiatives that the Center for Health Design, I think, has done a fantastic job of inciting and exciting the field about to use those principles. We should also think about affordability. So in closing, I'd just say this. The quality of the built environment for healthcare sends powerful signals to the patients and the communities. And I think, having visited La Maestra recently in San Diego, I don't know if there's anyone from La Maestra here, which was a building, a wonderful community clinic in San Diego, where they had originally started in a set of houses in a lower-income neighborhood, and now have this fantastic building that is LEED certified and beautifully designed, that is the hub of transformation of that neighborhood. That's a powerful signal to the people who get service there, and I think is a stellar example of what we're all talking about today. Against the backdrop I just described, I think facilities can be a service competitiveness differentiator if you have to earn those newly covered. And I think that's why the built environment is clearly very important. As Deborah said, there is a long history at the Center for Health Design of good design supporting quality and patient safety, and I think you'll learn about that from experts today. And I think there's a long history of good design supporting affordability and sustainability that we can really build and expand on, and it doesn't have to be quite as shabby as Walmart, in my humble opinion. I'd like to see us build a health system that works for patients, providers, and payers that is sustainable for the long run. And I think the best way we're going to do that is to learn from each other about what the best practices are. And I think that's kind of the purpose of today, is to really hear from the best of the best in this field and try and disseminate them more widely. And that's why I was very honored and excited to be here, and I'll be with you for the balance of the day. But I will take maybe a couple of minutes if we have. We're a wee bit late in getting off start to answer any comment, questions, or violent disagreement. Yes, sir.
Are you familiar with Michael Porter's views on healthcare reform?
Yes.
You don't have to go into them, but do you generally feel he's on target, or
He's. I generally feel he's incredibly smart and not always right. But certainly, I think. Oh, the question was Michael Porter at Harvard Business School. What I thought of his views, and I said he's incredibly smart and not always right. The argument is, where I agree with him completely, is that the basis for competition in healthcare is wrong, right? The basis for competition is on what I call pimp my ride healthcare, which is extravagant, excessive technology piled onto a tired old frame, paid for on a fee-for-service basis, rather than paying for value, paying for health status improvement. So that insight from Michael, I completely agree with. I think, however, that he has kind of an elaborate way in which he believes this is going to be played out, and I don't necessarily agree that it's implementable. But directionally, that central insight is we're competing on the wrong basis. I agree with. Yeah, that's a good point. Yes, sir, at the back.
I think you mentioned about 5 million new patients who would become insured if healthcare reform stayed in place in California.
Yes.
And I was just curious if you had a take on what percentage of those you think would come to safety net clinics, FPCH type clinics, rather than the private, or the private sector broadly understood.
Well, I mean, if you say you get your fair share, it would be 15%, right? No, you might say, well, why wouldn't we get disproportionate share? Because these are our people in our communities. Maybe, maybe not. It depends. I mean, so that's par, if you like. You know, if the total distribution of clinic visits is 15%. So, you know, I don't think 3 million people or 5 million people are going to flow through I mean, Melissa, you help me here, but I can't see it. I just don't think there's a capacity to do it. But there is a mindset, I think, in the community clinic movement that we are going to be overwhelmed with people, which may or may not be true. Bear in mind that, and this is the tricky part, is that because FQHCs, basically the payment rate you're getting is per visit is $150, and Medicaid's getting 30, right? I'm struggling a wee bit to see how you're going to be cost competitive in the exchange business. You know, that's a big differential, right? And if you look at the amount of private equity money that's floating around in Medicaid-only plans, if you look at who got the business in the exchanges in Massachusetts, it was not Blue Cross Blue Shield in Massachusetts. It was people who know how to do Medicaid managed care at a low price. And that may or may not be safety net, community clinic enabled. So that was kind of the whole purpose of both some of the work the foundation, California Healthcare Foundation has done and the Blue Shield Foundation has done. So, I mean, look, I'm a big fan of the clinics. You do noble work, but it's not a slam dunk. You get the business, right? Yes, sir.
I'm wondering, thank you. I'm wondering what the level of physician involvement is in the clinic design process, just kind of across the board. Have you seen much of it?
Well, that's way above my pay grade, but I think what you're going to hear today is exactly that question. I mean, I will say, if I channel myself back 30 years ago when I started in the business trying to do clinical redesign and clinical reengineering, you listen to the caregivers. I mean, we had a wonderful visit to family health centers in San Diego as part of our board retreat just a month ago, and Melissa and I were just laughing, you know, because I just took over as chair of the board from Jeff Cowan, who's a former, well, still a professor at USC, former head of the Annenberg School of Communication. And I could see Jeff wincing because basically the project we were being shown is the application of lean in a community clinic. And basically what we were being shown is we put the pencils in the drawer this way, you know, and it seemed like incredibly mundane. And I could see Jeff kind of wincing as to what's this about? Because we had just spent the morning with our new Secretary of Health, Diana Dooley, and that's sort of very high-level policy discussion. And now we're saying the California Healthcare Foundation is supporting which drawer you put the pencils in, right? And I said to him, you know, Jeff, this is incredibly important. And he sort of looked at me. I said, my colleague Ann Hendrick, who's served on Centre for Health Design Board, did this wonderful study to show that on a med-surg floor, nurses on a med-surg floor, when you track their behavior, spend about, correct me if I'm wrong here, Deborah, about 30% of their time in patient care, and only about 3% of their time in patient assessment, which is kind of what nurses are trained to do. The rest of the time, they're out running around trying to find the pencils. Right? So that's why it's important. We could double the productivity of the med-surg business if we put the pencils in the right drawer. Now, that's an overstatement, but I mean, it's directionally correct. And the only way he's going to figure out where the pencils are going to be, that people who use the pencils. So that's kind of what Lean is about. That's what redesign is. And I think, so why I have been proud to be associated with Centre for Health Design and California Healthcare Foundation is you bring these leaders together, people who know about design, but you have got, and then your question is exactly, the people who do the work have got to be involved in the transformation of the delivery system. That's a key point, absolutely. Yes, sir.
To marry Bill George's comment that people support what they help create, would you consider it wise or foolish to involve the community of prospective patients in what kind of design would you like, as partly to meet their perceived needs and also partly as a marketing ploy?
Yes, yes. I mean, I'm a big fan of listen to the customer, except when the customer wants to do something really stupid. Okay. And so I am 100% of asking the question, but I also believe, because you know, I see this in my consulting activity, nothing to do with design, is that no, half of what I do is kind of drag clients back from doing something really stupid, much of which was derived from talking to the customer. Sometimes the customer isn't always right and doesn't know. But generally speaking, as a starting point, yeah, sure, I'd want to know what their experience is. And by the way, I think we're going to get, I know a number of the foundations in the state are actually actively out there interviewing people who are uninsured and so forth, saying, what do you kind of want if you had a card? And I think that's a good starting point. So yes, but I wouldn't be slavishly following everything they say if it wasn't smart, you know, and if there were legitimate reasons for not listening to it. But I generally agree with your point. One more question. All right, we may be in need of a break. All right, thank you very much.
Thank you, Ian, for a great kickoff to our day. Before we move on to our next presentation, you may have noticed during registration we are doing some drawings for a couple books. We have done our first drawing and want to announce that Michael Nillmeyer has won our first set of evidence-based design educational books.
Okay, so I think we're all starting to get back assembled into this room. So first, before I begin, I want to introduce myself. My name is Amy Keller. I am a research associate with the Center for Health Design, and I am delighted to have all of you here. I have been working with the Center for Health Design and the Foundation on a lot of the tools and resources that we're going to share with you today for the last 3 years. So this is extremely exciting to me to see all of you here. So thank you again. And before I really start to turn the page over to our distinguished panel here, I wanted to start with a small activity. It's going to take about 1 to 2 minutes. And I want you to turn to each other, introduce yourself, and tell each other what you hope or what you think would be the most ideal clinic environment. So just take the next 1 minute, 2 minutes, introduce yourself, and see what the vision could be. So today's just the beginning of our conversation. So the panelists, which I'm very excited to introduce, to my left is Dr. Angeli Joseph. She's the Director of Research at the Center for Health Design. We have Ellen Taylor. She's also a Research Associate at the Center for Health Design. And we have Dr. Chabot Kwan. He's also a research associate at the Center for Health Design. And what all of us have been doing for the last couple of years is really kind of diving deep into the world of clinic design to see what evidence is out there and how it can begin to tell that conversation, that story of designing better facility environments. So Melissa and Ian both did a wonderful job of describing the current context of clinic design and what we're facing in the next years to come. But between now and 2015, there's over $10.5 billion in facility construction, renovation, and expansion, just in clinic design, community health centers, and so on. So here's a great, unique opportunity to rethink how we actually design these buildings, how we can provide better patient experiences, better experiences for your staff, for yourselves, and improve those organizational outcomes. So how many of you are familiar with the white paper series that was just launched about 3 weeks ago through the foundation and through the Center for Health Design? Okay, so this is just a brief, quick kind of a snapshot of where those white papers really started. And we have the authors here to really guide you through each of those papers today as well. So these publications are an opportunity to describe design strategies and how they can enable safety net clinics to support these best practices. There's 3 papers in all: designing safety net clinics for innovative care delivery models, designing safety net clinics for flexibility and adaptability, designing safety net clinics for cultural sensitivity. So these 3 panelists will highlight those ideas that were found throughout the papers, and then we will have a conversation, a dialogue with all of you, and explore some questions that are still unanswered or things that you might want to learn. These white papers were based on literature reviews, interviews, visits to some great clinics out in the field, and they also reveal a variety of issues that really highlight not only the healthcare experiences from a patient, provider, and a community perspective, but also they highlight the facility planning decisions that you'll need to really make those decisions moving forward. So really quickly, I know we have a lot of great individuals in the room, but I just want to bow my hands to the advisory council committee members that are here. So if you could just raise your hand in the room. These are the individuals that really help shape some of the conversations that we've had, some of the examples that were brought to our attention around the great work that's being done to date. So with that, I'm going to turn it over to our first panelist, Dr. Angelique Joseph.
Thanks, Amy. Thank you for the opportunity to speak with you all about these papers. As Amy mentioned, the papers are all available on our website now, and all the details you can actually find on that. Today I'm just going to go over some of the brief salient points so that we have a lot more time to discuss these issues with you all, make it more interactive. So the paper that I'm presenting talks about culturally sensitive design and why is that important, and how can design, or how can the physical environment really respond to the cultural needs of the different diverse patient population. And the reason this is important is because the American population is more racially and ethnically diverse today than it has ever been. And safety net clinics really represent the opportunity to connect these patients with the healthcare system, with good health care. So that's a very important need today, and these patients often represent different languages, different value systems, different beliefs about health and well-being. And it's important for not only the provider to provide care that's sensitive to their needs, but the environment itself can play a very important role in making that connection. Some key definitions or concepts that we hear about. What is culture? So culture is a collection of beliefs and behaviors that are learned and shared by members of a group. What's cultural sensitivity, especially in healthcare? This involves understanding the values, beliefs, and attitudes of providers and patients during healthcare interactions. So that's really important, to be able to understand what does the provider bring to the table, what is his or her sense of the world, and how people should be in terms of their health and well-being, and what does the patient believe, and to be able to bridge those gaps. And cultural competence is actually understanding these values and beliefs, and then being responsive, using your knowledge and capacity to respond to that and provide effective care. So these concepts are important to understand, and it's very important in healthcare in general today. But for safety net clinics, this is a serious challenge because there are people presenting themselves with various different backgrounds, cultures, and experiences that need to be responded to. On a one-to-one basis, a provider can understand and respond to a patient's needs. But the challenge is, if you're designing a safety net clinic, you see so many different patients, and they all have so many different backgrounds, different ways of looking at health. How can you provide an environment that responds to such a diverse population? So that becomes a challenge. It's not like responding to a single patient. So what becomes important is to understand what are the basic principles or that you can begin to think about while designing your facility. So the key thing becomes understand your patient population. What are the issues that you need to consider, and then design spaces that might support interactions between the patient and provider in the healthcare facility. So based on the literature review and the discussions that we've had with some of the clinics that we visited or interviewed with, these are some of the key issues to consider. Models of health and disease, they vary among different cultures. Some people believe that supernatural forces are at work, and that defines who you are, your health and well-being, and the outcomes that you're going to experience. Others believe in the biomedical model, where there are physical and chemical processes in your body, and that determines who you are, and that can be manipulated. While still others believe in a holistic model, where there needs to be a balance between the human body and what's outside nature and so on. So if there is a disconnect between what the patient feels and what the provider feels, there can, the health outcomes may not be ideal. So it's important to be able to understand where you're coming from, your own assumptions as well as the patient, and then bridge those gaps. And I think what we are contending and what we saw is that the environment can also play a role in helping bridge these gaps. And I'll provide some examples to talk about that. Perception of hospitals, doctors, and healers. This varies from culture to culture. In most cultures, doctors and healers are held in very high esteem. But at the same time, there's also a slight bit of a tension with the healthcare system, with institutions, and many patients might feel that they are not comfortable going, especially if they're uninsured or if they're, their immigration status is in question or whatever. They might feel a tension approaching a doctor or a healthcare system. So community health centers and safety net clinics really play a very important role because they're in the clinic and they can make that, they can bridge that gap. The kind of, where do different people fall in the hierarchy in terms of, in some cultures, people are all perceived equal, and irrespective of age or profession, the interactions don't matter. But in some cultures, there is a definite hierarchy, and sometimes, matriarchal societies or patriarchal societies, the patient often takes a backseat, and it's other people in the family or in the community who make key healthcare decisions. And it's important to understand those dynamics while interacting with the patient. And the environment also can play a role in supporting that or enabling those kind of interactions. Family and social relationships, again, many different cultures, family plays a very important role. Even healthcare is not an individual decision, it's a family decision because it affects everybody. So that needs to be considered. Communication norms, that is, in different cultures, there are different norms for communication. How do you make connection with someone? Do you make eye contact? Verbal and non-verbal ways of communicating, that is all very important. So as I mentioned, the paper talks about these different principles in greater detail and talks about how the environment can really be designed to address some of these principles. And these 5 principles that I had on the screen earlier were just some basic principles that seem to apply, and it's a good framework for thinking about designing for cultural sensitivity, but there might be additional principles to think about. So what I'm showing here are just some key design principles to think of, design recommendations that might begin to address many of these issues. For example, signage, symbol, and artwork has a very important role to play. The physical environment, through its design, the design of the layout of spaces, does indicate it conveys meaning. For example, the Native American Health Center, the 7 Directions, they use very strong signage that is significant in the Native American culture to show connection and to build empathy with their client, with their patient population. The symbols of the medicine wheel, the layout of the spaces, the circle has an important meaning. In addition, they also have community spaces where people can get together. And so it is not only just the visual imagery and symbolism that's important, but also providing spaces to have that integration with the community. So again in this particular community, they have public spaces, common spaces where they hold cooking classes, which is not only a way to engage the community, but it also provides some education and information to the community that is relevant to them. Also, many of these health clinics that we visited were beginning to incorporate community gardens that again engages the community, enables them to come in, maybe cultivate plants that are relevant to them or that are found in their environments, and then it is also a connection to nature has been shown to be very beneficial to patients and families. Another important element to consider is access. As I mentioned earlier, many patients are often critical or a little cynical about the health system and may not be easily approaching these health systems voluntarily. So it's important to make it very accessible. So locating clinics in areas where they can be accessed either via pedestrian route or through mass transit, that's extremely important. This is Clinica de la Raza, which is based in the Fruitvale Transit Village. It's located so that there is signage leading the patients and their family directly to the clinic. Even within the clinic, there are signs all throughout leading the patient and helping them navigate through the clinic itself. So, you can see they have used symbols that are universal symbols that can be easily understood, and often they couple that with signage in multiple languages so that they can be easily understood. So in addition, you can use color, color coding different departments. All of that is really important. I talked about how family is very important in many cultures, and so it's not just one person, the patient, who might be showing up for a visit. You might need to think about family members who might be involved in the visit, maybe one or more family members. And some of the clinics that we visited really paid attention to that. So they designed larger waiting rooms. They created spaces where family members, if they were accompanying children, they could play. In the Open Door Community Center in Eureka, they've incorporated larger exam rooms in each pod so that if there were more people visiting in the visit, then they could be accommodated. So, we're seeing a lot of very innovative strategies that many of these clinics are incorporating to address cultural issues quite successfully. But I think the key thing to understand is that there is no one recipe for designing culturally sensitive design or clinics. The key thing is to understand your population, what are their issues, what is really important to them, encourage them to be a part of the design teams, understand what issues need to be considered, and what affects their healthcare interaction, what affects communication effectively, and then design spaces to provide for those kind of communication. So that's what's really important to keep in mind. Then in addition, I think one important thing to keep in mind, and that segues into my colleague Alan's presentation, is that patient population changes over time, and as the demographics change, how do the clinics address that? How can it still stay culturally relevant and sensitive even as the demographics change? So that you need to build in flexibility into your design to address those issues as well. That's just a very quick snapshot of what you might find in the paper, but hopefully this will give you some, provoke some thought and lead to some additional discussion later on.
Okay, so now we move on to the next topic for flexibility and adaptability in healthcare.
And I think one of the challenges that everyone always has is that it's very hard to design a building when by the time you open, chances are things will have changed. And in healthcare, this is particularly evident because you have changes in population, changes in the services, equipment, technology, the care models that you're using. And what ends up happening is that you have to relocate things, or you have to renovate, you have to expand either vertically or horizontally. So we went through this literature review to try and figure out what have people done in healthcare that can be some lessons learned for safety net clinics and for your organizations that have often never undertaken a project like this before. So there was a couple of frameworks that we really found that outlined some of the key premises for design. One is called learning buildings and one is called open buildings. And learning buildings was really something that was developed by Stuart Brand, whose basic premise is that buildings are not designed to adapt, but they do anyway. They are sort of their own force of nature after we move into them and we mold them into what we need them to be. And the real idea is that you have a series of layers that are designed for different time spans. So you go all the way from the site, which is eternal on one level, to the structure of the building that's going to last for several decades, if not more, to the skin of the building that may be, maybe a couple of decades, somewhat temporary, the services that are within the building, all the way down to what he calls the stuff, which could be anywhere from a day to a month to a couple of years. The open building concept follows a similar framework, except it's only 3 categories, where you have a primary system down to a tertiary system, ranging from 5 years all the way up to 50 to 60 years. So it's really trying to look at how do the components of the building fit into these different layers, and then how do we design within that context. So there's no research available in this topic for clinic design, so what we ended up doing was saying, well, what have other areas of healthcare learned about this, and how might we be able to apply that to clinic design? This is actually an example from a paper that was written about emergency room design, which is an area that has to have a huge amount of flexibility and adaptability because of all of the different types of care that they're providing and the types of people that are coming in and out. So one of the things that this paper really looked at is identifying a universal grid. And this isn't a series of walls. This is actually just a theoretical grid of how you design a building. And the sample on top just shows how you have a structured grid with a circulation spine along the middle, and then you have a series of rooms that can be sort of plug and play within that system. On the lower side, you have this modular system where, depending upon the amount of space that you need, you can expand that module. So you pick your smallest common denominator and say, well, this function would need 2 of those, and this function would need 3 of those, and this function might need 4, but it's all based on that same modular system so that it's easy to swap things out when you need it down the road. It's also a great way of saying not each one of those modules actually has to be a room. So you can have an open furniture design that defines that space. You could have a wall that's set in with a little alcove with casework or some other things built in, or you could actually have a whole walled room. So there's different ways to function within that modular environment. Within that modular environment, it also starts to bring up modular systems and how you can really use technology to be flexible. So the picture on the left-hand side is just typical of what a lot of furniture companies are offering at this point, where it's a system where the framework mounts on the wall and you can just plug these different components in. So whether it's a counter system, whether it's a sink and cabinetry system, overhead cabinets, you can move things around and really make that room as flexible as you need it and change it down the road. The picture on the right-hand side is highlighting one of the clinics, the Grace Hill Tower, where they actually used a flexible arm for the computer screen. It's 56 inches, so that a care provider can use it in a lot of different ways. They can be sitting on the stool, looking at the record, or they can be turning the screen around to show the patient or the family members, as Anjali mentioned, and really accommodates a multitude of ways of delivering care to that patient. Another thing that we came up with was some studies that had been done in inpatient units and trying to figure out what makes flexibility in an inpatient unit, a typical med-surg type unit. And one of the things that really came about was visibility, whether it's visibility of your peers, visibility to the patients, visibility to the support core functions that you need. Ian mentioned the looking for the pencils. How proximal are those things? How easy is it to find some of those different components? So this is an example of Clinica in Colorado. Is anybody from Clinica here at all? So they have a couple of different facilities that are highlighted in the papers. In this one, you can actually see on the upper part of the plan and the lower part of the plan, they used an open furniture system, low walls, so that people could see each other and be able to see if their colleague was there. They also have a direct line of sight out to the waiting area and the reception area. So everything is very open and gives them a very easy way to see what's happening within the facility and provide that level of care. Another thing that came up was acuity adaptable rooms. Again, in an inpatient unit, a med-surg type of environment, but what are some of the things that we can learn from acuity adaptable rooms? Well, an acuity adaptable room is a room that basically the care comes to the patient instead of the patient being moved around the hospital. So the head wall is designed that it has everything in it that you would need. You might not be using it all the time, but if someone is an ICU patient or a step-down patient or just a standard type of overnight patient, they can all use the same room, and you can sort of plug and play with the systems that you need behind that. So in clinic design, this is really popping up in a lot of the pod designs that are being used, really having the same type of room that's being used throughout the pods so that people are familiar with where things are and how things function. And again, it gives you a great deal of flexibility when you're trying to move things around, and somebody can work in this room instead of this room, and they're not going to have to refigure everything out again. And then this standardized room is replicated within a series of pods so that, as Jabot will talk about, you can have that sort of home care model. Another aspect that we really looked at was this whole notion of incremental growth. And this is a diagram from the Rural Critical Access Hospital study that was done. And what they really looked at is how do you design a facility so that there's always this ability to expand out. And they really looked at what happens with multiple entries, what happens when you design something with a circulation spine, so that those things that are not going to move, the mechanical, electrical, structural components, are all there, and everything basically lobs onto it into a different type of form so that you can expand out in the future. And then we get to the business case, and I think the advisory committee found this probably to be one of the most compelling aspects of what we're talking about with flexibility, because many of you know, if you've embarked on a project before, that you have some hard decisions to make about how to best spend your money. And a lot of times when we're looking at some of these components to provide a universal room, it might be a little bit bigger than maybe sometimes you might need for a room. And that means that it's probably costing you a little bit more. Or if you're going to outfit it with all the same components so that different people can be using it at different times, that might start to cost a little bit more. But what this diagram really shows, and this is done from a literature review with a number of different organizations that really looked at the difference between a building that was designed with flexibility and adaptability in mind and one that wasn't. And what it really looks at is the whole life cycle analysis of a building and the initial capital cost to the overall operating costs of the building, which capital costs are big, but operating costs are much, much, much bigger. And ultimately, that's where you're going to find the long-term savings. So what this diagram really does, a standard design is the solid line. And you can see that after the building goes into operation, you start to generate some positive cash flow. But then you have some big maintenance items, so your cash flow is going to go down because you have to pay for that. Then you have a renovation, and then you're going to have to pay for that, so it starts to go down. And eventually, you get to the point where the building cannot be adapted anymore. It becomes obsolete, so you basically have to find a new way to use it or move to a new location. A building that's designed with adaptability and flexibility in mind might cost a little bit more on the front side, but once you get into the operation of it, it's designed with that ability to adjust over time so that you're actually generating more positive cash flow in the long-term life of the building. And with that, we'll turn it over to Jabot.
Today I'm going to talk about the white paper on safety net clinic design to support innovative care delivery models. Faced with a series of challenges, safety net clinics have been constantly engaged with innovative care delivery models to more effectively and more efficiently to serve their patients. Because the physical environment is a very important factor impacting the performance of care delivery, and the guidelines on these topics are very limited. There's an urgent need for us to better understand how the physical environment can be supportive to the innovative care delivery model in safety net clinics. The purpose of the paper is to identify common design features and also provide preliminary design recommendations in relation to innovative care delivery models. The white paper identified 5 common supportive design features for innovative care delivery models, including co-location of services, outreach of services. This table is, the font is really small. The table is in the appendix of the white paper. The 5 common design features also including patient-centered care, space for team collaboration, and the use of new technology. Under this table, which also appears in the appendix of the white paper, shows how each design feature applies to different care delivery models and different clinic examples. The first supportive design feature is co-location of services, means the integration of multiple services, functional spaces, such as health clinics, dental care, patient education, and child care in one location, in one building or the site. This supports the one-stop shop and the comprehensive care of individual patients. We have this slide shows a great example in California, and we're also including other great examples in the white paper. When we design a multi-service community center or health center, we need to first determine what services to be provided based on the greatest needs of local community. Then we should go ahead to pay special attention to wayfinding issues and to facilitate patient flow, because when the building becomes more complicated, it will become more difficult for patients to find their destinations. The second design feature is the outreach of services, including mobile clinics that move healthcare services closer to the remote patients in rural areas. We have very good examples in California as well as other parts of the country. Some design considerations for mobile clinics, including the size and the layout of the mobile clinic, the size and the location of the windows, and the air conditioning and insulation design, the finished materials for ease of maintenance disinfection, and a barrier-free environment for disabilities. A very important component of many innovative care delivery models is patient-centered care, which usually is supported by a healing, empowering environment. Design recommendations including making the environment more welcoming, less stressful for the patients, and providing extra spaces and amenities for families of patients, and also ensure the physical comfort, including thermal comfort, visual comfort, and privacy of patients. Team collaboration is critical for many innovative care delivery models, emphasizing interdisciplinary team care of patients and also a holistic care approach. It is recommended that the space for team collaboration, including visual connection and information sharing between staff members, informal meeting space, informal collaboration space near workstations, and comfortable adjustable furniture in the meeting spaces ensure information security and minimizing distractions. Last but not least, the use of new technology, including telemedicine, has been widely used in many innovative care delivery models in safety net clinics. Telemedicine can take different forms to serve different needs of various clinics, but there's a common set of design recommendations, including a component-based framework that is cost-effective and a flexible design that accommodates future changes in the technology, and also some special considerations in lighting design and acoustic design for the video conferencing room. This is just a very short summary of the white paper, and we also have including a lot of other additional examples and detailed design recommendations in the white paper.
Thank you, Chabot, Anjali, and Ellen. So before we get to the dialogue and the question portion of this segment, I just want to say, in summary, there was a lot of commonalities and parallels between the three papers. And we organized these parallels into three settings: one, the patient experience, the community experience, and the provider experience. So in summary, what we've heard from the three papers was, for the patient experience, to provide a welcoming, familiar, and unintimidating environment. Patient-centered care is at the core, developing those personal relationships, providing an opportunity for one-stop care, ensuring that the family member is there and participating. For the providers, we saw that interdisciplinary teams, collaboration, and group efforts really help in terms of providing additional interactions, and also incorporating technology and making sure that that is a moving, innovative feat that will help your teams explore new discoveries. And then community, ensuring that the location where you actually site your facility is incredibly important. So location, location, and location. Wayfinding, how you make sure that you can provide those opportunities for people to find where you want them to go. And then also providing outreach programs. So Chabot mentioned the mobile clinics. There's also a lot of different programs that the community clinics and community health centers have embraced and so on, such as Meals on Wheels and so on. So now I just wanted to start the dialogue between all of you and our panelists here. I have a few questions prepared, but then we're going to also turn the mic over to you all. So the first question that I have for Anjali is actually, so I'm curious, if individuals from multiple cultures visit your clinic or anyone's clinics, how would we address the needs of this diverse population?
I think one important way in which you can begin to address different populations, at least that what we've seen through the case studies that we've done, is through artwork. As I mentioned, the building design gives visual cues, and so symbols, layout, signage, all of that conveys information. And some clinics have very effectively used artwork from many different cultures, so they can actually donate their artwork for sale or for display. So depending on the patient population, you have a diverse set of populations represented. Then I think also providing spaces, I had mentioned earlier, to have different kinds of community activities. So, you could be celebrating community festivals, depending on who your population is. So it could be used for multiple ways. And then the third way that I would say that this is an effective way to engage different populations is by making them part of your design and operation team, involving them in the design process, empowering them to make decisions or to support the process. I think those are some ways that that come to mind.
Does anyone else have any other suggestions for the group in terms of how to incorporate multiple cultures in your clinic environment? You can always have a, yes, go ahead. So the suggestion was to go out to the community and receive feedback in terms of what they would envision, correct? Okay.
And I think some of the communities are doing that through focus groups. When they're involved in the design process, they will probably have focus groups and invite community members. I'm not sure I came across examples of the clinic team going out and canvassing them. So I think that's an effective strategy as well. Different ways of getting information from the community about their needs and what really works for them. That's important, I think.
There's one example actually on our website, and as repeatedly said that all of this information is available on the Clinic Design website, as well as the white papers can be downloaded on the Foundation's website as well. But La Maestra, which many of us have cited earlier today in the discussion, they have over 26 different cultures that are represented within their community. And Zara, who is the CEO at La Maestra, has proven to hire at least one person from each of those cultures. So when they were going through the design process, they really tried to embark many different ideas of what a community health center could be for that type of environment. So that is one tangible application, how they're incorporating multiple cultures. Yes? Way back there. Great.
One of the challenges we face is different cultures. We have a homeless culture. We have a lot of homeless youth that live in the park, and there's a school down the street, which is a private school, and kids there, their parents make over $200,000. And there are youth coming in from these different cultures, really affluent neighborhoods as well as, and I think one of the things that has worked with us is modeling. When there's a really smelly homeless youth in the waiting room with kids that don't want to be around that person. I think we have a lot of peer health educators, so we model good behavior and tolerance in the waiting room, and I think we've become a lot more sensitive in our hiring process as well, and training our staff to deal with conflict in the waiting room. I think conflict in the waiting room, thanks to different cultures, has been a huge challenge for my clinic. And I think educating staff and having staff, peer staff, really helping in the waiting room to diffuse certain situations has really helped us make our space safe.
Great. And can you just repeat real quickly for the group what clinic you're from?
I'm from the Huckleberry Youth Multi-Service Center in San Francisco in the Haight-Ashbury district.
Great, thank you. So I have another question, and this is for Ellen. I'm curious, because you talked about flexibility and adaptability, if they are essentially the same thing, or are they different issues, and how should they be incorporated?
Actually, when we were doing the literature review, we found that they're defined somewhat differently. So adaptability is defined at a more strategic level. So perhaps down the road, when you have new services that you're incorporating, your building needs to adapt to new models and new services. And flexibility is a little bit more solution-oriented and a little bit more tactical. So providing a multi-purpose room that can be used for different types of events. But one of the things that we talk about in the white paper, at least we touch upon, is this notion of scenario planning, and that can be used on both adaptability and flexibility. So you can actually look at, well, what happens in a scenario where, Anjali brought up, you have an entire family coming into the exam room. How does the exam room function at that point? So that needs to be a very flexible room, and you're looking at it on a very solution-oriented basis, versus a scenario where you say, what happens with healthcare reform, and now all of a sudden my entire world changes. So let's just play out 3 different ways that might happen, and how might my building adapt to that? So they are related, but somewhat different.
Great. So for those of you who are in the room, I'm not sure if we've done this already, but how many come from the design profession? Okay, and I'm assuming the rest of you come from the clinic profession, correct? Okay, so I'm just curious, if you're currently embarking on this design of your new facility, or you're renovating your new clinic, have you had some sort of dialogue with the design professionals that you've hired about flexibility or adaptability? Does anyone want to have a quick comment on what those kind of questions and conversations have been?
Hi, I'm Maria Montanaro. I get the prize for coming the furthest from Rhode Island. And during the breakout session, I'll talk about the patient-centered medical home and this idea of transformation. But to answer your question, Amy, I think it's very important that, and we did in the 2 health centers that we've designed, the one that will open in June and the one that we designed that's part of the case study from that we designed in 2005, to have this conversation about adaptability and flexibility both with the designers, with the architects. And in fact, what we found as we were interviewing the architects was that the thinking among the architects was somewhat rigid. So as we and we were putting in ideas that were untested. So one of the things that we did was we took our design team to see 3 or 4 buildings of each of the architects that had made presentations, and we were scoring them on flexibility and adaptability. And it was interesting because if you haven't picked your architects yet, I suggest you do this. You go to places and say, how come the counters are this high? Well, this used to be the PD clinic, and now it's the adult clinic because they ran out of exam rooms. And so when you start to see stuff like that, you see lots of really literally dead ends in the design over and over and over. Talk to those architects, and they say, well, the client was not flexible. The client didn't want to hear it when we tried to talk these things through. But part of it is that I think that the designers have to be willing to push a little harder on getting clients to think about the building of the future rather than the building. You can't really build what you know. You have to build into what you think, how you would practice, how you should practice, how you might practice if only things were to change. And as we started to do that at Thundermist, our architects said, boy, these are great ideas, but who's doing them? We said, well, we don't know, so we'll give you 6 weeks. Go study the literature, go find out, go figure it out. They came back and they said, well, nobody's doing it. So it's either so stupid, everybody rejected it, or it's so smart, nobody's thought of it. And you'll have to decide which one it is, because we have nothing to tell you. So when you start to get out on those limbs, I think it's really important that the design people bring information. There's a lot of innovation now. They bring this information to the table and they really challenge those traditional notions, because without it, all of this money that we're spending on building really leads to this kind of retrofitting. Just 2 years, it was sad. We went to a few of these went to these big health centers. I mean, tens of millions of dollars spent, and said to them, how long have you been in the building? I expected them to say 10 years, 12 years, 2 years. 3 years. They're remodeling entire sections of the building. So I think it's very important that you have a process by which you take time to really study models, go visit things, not just the architects that you might be working with, but other trailblazers, to really think about how will I get that patient-centered medical home redesigned? How am I going to push out these ideas of what am I going to do when 25% of the visits are telephonic, they're telemetry? What am I going to do when 50% of the visits are talk instead of exams? How am I going to deal with that? And try to really push those models forward.
Great. Thank you, Maria. Yes?
Hi, I'm the CEO of Sonoma Valley Community Health Center, California. And we haven't started our design process yet, but I've been researching for about 1.5 years. That's what brought me to your website about 1 year ago, maybe 9 months ago, and was delighted to see that there was something about clinics, because my question has always been, how do you design, who's designed, where is, design the flow for the best, revenue flow so we can pay down our debt when we do this debt. Mm-hmm. And so I want to know what is, the most productive, what is, adjacencies and things like that. And flexibility and sustainability was one of the things that I was looking at. And I heard New Century Healthcare in San Francisco had said, if you're going to buy land that you can develop with at least 50 to 100 years out. Mm-hmm. And I thought, well, 50 maybe. 100, I don't know. But, that way you can have some, when things move and shape, that you're not going into, another building across the street or down the street or whatever. And then the other part was some people building shells inside their, their 2-story or 3-story and don't, do anything with the shell, parts of the shell, 1/4, 1/8 of the shell, and that seemed kind of interesting to me too. So I think our health center, we've been at this little 3,500 square foot facility forever, And we've flexed it about 5 times since I've been there, so you do have to look at that.
Great, thank you very much. And we have one more question, and then I have a couple of other questions too.
Technology and the idea of electronic medical records needing to be securely shared, updated, used during normal clinic visits, influencing the parameters and the sort of the design factors that each of y'all studied and wrote about. I don't know whether it's just a question of where you put the wires and making sure that that's all squared away, or whether it's application-specific rooms for things like telehealth. I'm just curious exactly how that factored in, because it's obviously going to be an issue, a huge issue going forward. So
I think I can start with that, with flexibility and adaptability, and it will segue into some of Jabot's discussion of telemedicine. I think almost every clinic that we interviewed basically said that IT issues were the barrier in terms of their flexibility over time. The beauty is that now that we're moving into a wireless world and technology getting smaller and smaller and smaller, that's becoming much less of an issue. So whereas before people were telling us, well, we couldn't do this because we had to double the size of our server room and we just didn't have the capability of doing that, now all of a sudden it doesn't really matter because all that information is floating out there, the infrastructure is already in place, and you can just provide the services in wherever the building you need to be. So it is providing for a lot more flexibility, but there are some specific considerations for areas of telemedicine.
I think this question is kind of related to both telemedicine and also mobile clinics, because mobile clinics also use a lot of wireless communication or satellite communication even. So I think that this is also going back to the needs of the community. So the needs of the community will change in the long run. So there's no definite answer to that. I think it's a flexibility issue in relation to innovative care delivery model. When the society evolves, the needs of society and the needs of population we are serving now change. So yes, just mentioned that we may have expanding population to serving in the next couple of years. I think this is keep changing. We need to keep track all the changes and just prepare ourselves to all the changes. So that's like.
And technology, especially electronic medical records, have a big implication from the communication perspective, and that's often a huge challenge in the exam room. You bring in this computer screen, and you expect the doctor and the patient and the family members to converse around that, and it can be challenging. Often it's like a barrier between the patient and the doctor. The doctor's using it like a shield, and that's not helpful, because not only do you have all these cultural issues about making eye contact and talking, and then there's this computer in the middle, and what do we do with it? So that becomes an issue, and how you design the exam room helps with that. We've seen examples where the computer screen is located where the patient and the physician all have equal access to it, so it helps to reduce that power differential, and you can talk about it. You can have the computer screen on a flexible arm, so you can move it around so that it's equally accessible to everybody. So that's an issue that that's more about the communication, the cultural issue that needs to be figured out, and a lot of it depends also on the provider and his competence with using the electronic medical records, and how he or she can engage the family and the patient into it. But it's an important consideration.
Yes?
I have a question about the IT implementation in the clinics. Once we locate the flexibility of the IT and the wires, and that sounds great. Now we put the systems up with our softwares, and then we're having to update versions, and then we have problems per se in the rooms, because the version was updated last weekend and our providers are slow, and that's part of the flow, and that's part of our wonderful flexible building. Do you have a suggestion how to deal or how to choose for our clinics our next step in IT coming? Because a lot of us have tried some systems, we're having glitches, and it affects everything. So I don't know if that's part of this design, and if you have any input on that. Thank you.
I I'm not, I would maybe ask and kind of rephrase that question in terms of asking our advisory council for that particular response, just from the standpoint that we didn't necessarily look at the technology implementation factors. We looked at how technology in a entirety can be integrated within the facility. So does anyone from our advisory committee have a comment on the technology integration component? Yes, Maria?
Thanks. You're raising a good point about the technology, and I would have a couple of suggestions. One is that if you're not, how many are not on an EMR or yet? Raise your hands up high. Yeah. But you probably will be in the next 3 to 5 years. It's almost a foregone conclusion that without an EMR, really not going to be competitive in the future. Thundermist built its first building in 2005 in this radical redesign of a paperless system before we were on an EMR. But we contemplated a lot of the workflows in a paperless system. The second building that's opening next month, or in a couple of months, we've been on the EMR now for 3 years. So one is if you haven't selected an EMR, you really need to go through a very rigorous process of really understanding what you're buying. And you're not really buying to automate the existing systems, you're really buying to manage quality. So you really have to take a good look. And most states, including California, have some pretty good regional health forums about that utility and accessibility. But from the design standpoint, I think the big issue that gets missed is it's not enough just to think about where are the server rooms and how do you put the articulating on, how are you going to use the EMR in the exam room, but rather the implications of use of electronic records toward population-based medicine and the changes, the workflow changes that is creating and should create and will create in the future design of your health system. So if it's done well and right and payment follows quality, the encounters per hour are going to drop. The care coordination is going to increase. The spaces you need for that care coordination look very different than the spaces you use today. Thundermist is an NCQA Level 3 patient-centered medical home. The space in our new building looks totally different than the spaces we built 10 years ago. So the paperless systems, the opportunity for paperless check-in and paper out of the system entirely, the opportunity for instant messaging and visualization of flow, audio and electronic visualization of flow rather than paper handoffs, really change where you can locate spaces. I always make this joke in healthcare, it was just one big elaborate relay race, and the chart is the baton, and everybody's got to get in zone for the next handoff, right? That's why those medical offices are as big as they are, because everybody had to be in the zone. The patient, the chart goes in the bin goes on the door, it's a whole system. It was really designed because you couldn't have this communication flow across long distances without a handoff. Now you can. So you can do things like completely eliminate the medical office, which is what we did. You can do lots of things. So you have to think about the use of the technology, how that's changing your patient care. And then, the lowest rung on that ladder is where are the rooms? Those are important things. Where are the rooms? Where are the laptops? Where are the wires? But the more important thing that people miss is what's the use? And how does the use change the flow? And how does the flow change the design?
Also, I would just want to kind of reiterate the statistics that Ian shared with us earlier about technology and how that's changing the 10 million e-visits that Kaiser Permanente has, the 8 million prescriptions that are filled online, and the 2 million same-day appointments. So obviously technology is rapidly changing, and how we incorporate those changes into the facilities are going to be either successful or not. So I don't think it's going away.
Back up to the question about site selection and looking at this issue of 50 to 100 years. How many people are embarking upon the design of a clinic? Okay, so in addition to the issues that were raised in terms of the site and the ability to expand your facility at some point down the road, something that people might not necessarily think about is the zoning regulations and how high are you allowed to go? Are you allowed to put a second floor on or a third floor? Are you designing the building structurally to allow for that? What happens with parking? If you're not near a public transportation system and people are driving to your facility and you're using that area for expanding the building, but you don't have an area to expand the parking capacity, this all starts to tie in together. So it is really important to start looking at these scenarios of, okay, what happens 10 years from now when our patient volume is here? What would that building look like?
Great. Yes, we have a question over here.
Yeah, I'm Andrew Ma from Asian Pacific Healthcare Venture, and I'm just wondering on your literature reviews if you ever came across disaster preparedness and designing within the clinic in terms of holding caches of medical supplies and also the backup system or command centers that we have to start planning on with, the health departments.
Mm-hmm. It's not something that I came across in my work on the cultural aspect of it.
I don't think I ran across that particular item, not to say that there's not lessons to be learned from other areas of healthcare.
I think one example, not necessarily from the clinic world, and it is a safety net hospital, but LSU, the Hurricane Katrina actually, obviously in 2005 hit New Orleans, and what LSU actually had to do with their charity hospital in terms of developing preparedness and guidance. They're currently planning the new charity hospital right now, and they have valuable lessons learned that they are now applying to their buildings, and they're sharing their work with others. And that not necessarily lives on the clinic design portion of our website, but if you do visit the healthcare design or the health design website, you can see a little bit of LSU's story on Charity Hospital. And what we can do after this particular deep dive seminar today is maybe pinpoint that particular presentation that highlighted the design changes that they're making, not only with their ER, but with their hospital wide to plan for the 100-year flood, the tsunami, the earthquake, everything that we have to be prepared for. Doug?
I was just going to comment on the emergency preparedness because it has become a big issue for a Joint Commission, which is very important to us. And what we've learned, what we've gone to is not so much building more space to handle emergencies, but we've become more networked with the community of emergency services in the county and the state level. And that has not been an easy road, but it has been fruitful in resources. So we may not build a room to house more stuff, but we do have a connection with people to say, hey, if something happens, you can come here. And then we've experienced things like trailers to put stuff in and things that the county has done to say, oh, well, there's this great health center right here in the community that everybody's going to run to anyway if everything goes wrong. So let's use that. And so they've incorporated us in their plan. Now, this is an interesting concept because it worked in the county that we're in, but then when we moved to another county, we found a totally different paradigm where they were not so welcoming to the community clinic safety net world, even though we're serving more of their patients than private practice or hospitals. So it's an evolving thing. And you bring up a great point. It's great to consider that in design, but I think the answer is in community work. It's operational.
The other example that just came to mind is, has any of you been to Bolinas Community Health Center in Marin County? So their facility, which opened a couple years ago, actually was sited and built on the same location of their fire station and their EMT services. So what they do is that they actually share resources, and they share programs and amenities and equipment and so on. The helipad is between the two locations. And the idea there was because they depend so heavily on the EMT and the ambulances and the fire station to really help their work, why not build their clinic right next to each other? So they definitely use the resources wisely there. Cindy?
I just wanted to add a comment on emergency preparedness, that as I visit health centers that have gone through emergencies to see what has failed, it usually has not been that they didn't have the right equipment or the right spaces, it's that they didn't have the right adjacencies. And so when you're organizing your spaces, I think that some of the creative things that we're trying to do to meet the needs of communities as far as deal with walk-in patients and same-day sick and immunization clinics and all we can use for emergency preparedness as well. So looking at things like your large community rooms are great triage places, but they would be a lot better if you had a couple private exam rooms and you had the ability to do some basic lab there. Looking at your waiting areas, are there exam rooms adjacent to it that you could also use on a daily basis to do some initial triage on walk-ins, but they would be tremendously helpful in an emergency as far as triage. So there was earlier mentioned the concept of going through some scenario analysis, and I think looking at how you manage surge on a day-by-day basis gives you some good ideas on how to manage real emergencies too. And it really gets down to decentralizing some of your private examination and assessment areas.
Great, thank you. We have a couple of questions, Melissa, and then over here.
Well, I was just going to comment on emergency preparedness. I, visited about 8 different health centers around the United States, and everybody had emergency preparedness shed. And it took parking lot space that they didn't expect. And so they were down parking lot space. And so I was looking at our first design, should we design it off the parking lot? Can we design, instead of a container, make it look a little more attractive, and, because it's smaller, would it, we could get in it and move things around if an earthquake happened. And then I was thinking, it's got to be by a door, just, the emergency preparedness stuff can only hold so much, and then you have rest in the clinic. Maybe the supply room should be on an extended outside door where it's adjacent to the emergency shed, or whatever you choose. So I'm still looking for a shed that would be built and not a container, so it would look good. So if anybody has any ideas, let me know.
Great, thank you. Melissa?
So I just want to go back to the comment on the technology and just echo what Maria said. As you're thinking about implementing technology, when we've worked with some of the early adopters who've implemented EHR, the #1 learning that they've had is, and they wish they did more of, was workflow redesign. You're not taking a paper system and just making it electronic. You're really changing the way you do work. So as you're building towards that, if you have not yet implemented your EHR, you really need to think about what your staff is going to be doing, how the workflow is going to be changed, and be building towards that. Staff responsibilities, staff jobs are changing with the implementation of technology, who they're going to have to be working with, what kinds of things they're going to need, what kinds of adjacencies they're going to need is really going to change. So you need to think about that work and that change before you design a building. And down to the MA, the doctor, the provider, the administrator, everyone who's implemented an EHR has said workflow redesign is the most important thing in implementing an EHR, and is actually by far the biggest cost associated, not the technology. So I just want to echo that you need to be thinking about that. And if anyone is interested, we have some tools around that, some workflow redesign tools and toolkits available on our website. I can direct you to other websites. There's a lot of information out there about that.
Great, thank you. So we have about 5 minutes left, so we have a couple more questions that we could have open discussion around. Ian, yes.
Just a build on Melissa's and then a question. I mean, I agree completely. It's all about workflow and work redesign. As you're doing these scenarios, think about the cell phone as the key device for the future, because increasingly that will be the platform for delivery of a lot of services potentially, particularly for low-income populations, I mean, because of the ubiquity of that. And what does that mean? So here's the other thing I'd be really curious, 2 questions, I guess. One is containers. Somebody mentioned containers. I'm a big fan of containers. The cloud, everyone talks about the cloud. It turns out the cloud is a parking lot in Chicago full of containers, each of which is full of 2,400 bad Dell computers wired together, right? So it's not quite as glamorous as we might all think. So my question is is anyone using containers in healthcare to do really cheap solutions that work well? So that's question number one. Question number two is, I loved your fire station next to the clinic deal. And La Maestra, when we visited it, the board visited a couple of weeks ago, I mean, they clearly are, you know, multiple land use in one place. So I'm busting out my old planning degree here. So is there anyone doing multiple land use clinics? Housing is the other thing, you know, I mean, because you know, I mean, I know in Canada that's been a big thing in terms of care as safety net, is co-location of that. So a question is, anybody doing anything interesting with containers? And second is, what kind of land use adjacencies or multiple use in one place have you seen?
Well, I can just start the answer, and then I'll pass it on to the panelists. But La Clínica de la Raza at the Fruitvale transit station, I'm not sure if you're aware, but that is a great example of a clinic that uses a multiple land use options. So they designed this clinic, and Anita Addison is here in the crowd, to be designed around the transit hub, so a BART station. They also have, you know, a cafe, community members that open shop. They have a daycare center. They have a travel kiosk that you can go to, and then they have the clinic right there. So in a nutshell, that clinic is designed to be the central hub of that particular node within that transit zone. And I don't know if, Anita, you would want to mention anything addition to how La Clínica approaches the land use problem, which might be valuable for the rest of us to hear.
You did a good job at explaining that. So we partnered with the Community Development Corporation, the Unity Council in Oakland. So it was their vision to have a mixed-use development around the Fruitvale BART station. So we're one of the anchor residents, and we have a 40,000 square foot facility, but the whole complex is about 200,000 plus. And so you've got a Head Start program, you have a senior center, you have a public library, there's a charter school there, there's some restaurants and shops, but it's primarily anchored by the social services. So we opened that site at the end of 2003, and so it's been really a successful project for us.
Great, thank you. Ellen?
So in terms of containers, there actually is some work that's being done in terms of using containers as clinics. And I think Anshin and Allen designed a prototype, and it's a couple of years ago now, but it came up again after the disaster in Haiti in the context of being able to ship a fully loaded clinic to any of these disaster sites and be able to open up shop on day one from the moment it gets there. But they have some layouts and some recommendations on how that all works, and containers are everywhere and they're dirt cheap, so it is actually an interesting solution.
And that partnership was with Steelcase and Anshin and Allen, now known as Stantec, but that was a container, what you see typically on a barge that travels from China or Europe or wherever, and if you live in the Bay Area, you see these all the time, these big giant containers. And yeah, they turned those giant containers that were empty and no longer used to be a fully functioned clinic. Okay, so we have a really exciting afternoon for all of you, and I'm just going to spend the next maybe 2 minutes just highlighting what is ahead. And then you have a delicious lunch in the other room, and I would, before you actually leave this room, I would just keep two things in mind as you go on for the rest of the day. The lunch is really for you to network with your peers here. So if you do not know someone, introduce yourself. Ensure that you create a dialogue with them, explore where there could be some collaborative efforts, some opportunities that you could learn and bring back to your home, and so on. After lunch, we're doing something exciting and new. We have 10 different experts in this room, so I want all of the 10 members that are going to be leading the discussion after lunch to just stand so everyone in this room can kind of get an idea of who they are. And there's 10 different topics that will be discussed, ranging from business planning, capital financing, creating spaces for alternative types of patient visits, pre-move considerations. You can ask the architect. We have a couple of architects available here. Incorporating the medical home, wayfinding, owner decision-making, integrating technology to support patient care, and also learning how practitioners apply evidence-based design. So the idea for the knowledge exchange is you're really supposed to choose your top 3 topics and try to go to at least 3 tables, spend 20 minutes at each table. Well, there's going to be a bell after 20 minutes, and then you can move on to the next session. So it's basically like speed dating, but clinic design dating. So, so really spend 20 minutes, get to know your colleagues, explore those topics. Don't worry if you have 4 areas that you really want to learn about. What we've asked these experts to do after the fact is they will write down the dialogue, the summary discussion points that were heard within their 20-minute sessions into a one-page quick sheet, and that information will be available on the clinic design website in hopefully in the next couple of weeks. So feel free to look there. And you also can stay in one group if the discussion is extremely stimulating and rich and you just want to learn and keep learning more from that particular group. But just keep in mind that we're really hoping that you all bounce around to at least 3 different tables. All right, so now I guess we can go to lunch. Thank you very much.